I'm Dan Duffy. I'm a board-certified specialist in physical medicine and rehabilitation. I'm a doctor who helps people who have been injured. I've been asked today to talk about traumatic brain injury due to motor vehicle accident. In my opinion, there's three specific areas that I get involved with a patient who's been involved in this type of an issue. They're as follows. At first, the patient's in the hospital. The second, the patient goes to a rehabilitation center. And in the third, the patient is returning back to the community. My role is to coordinate services for this patient, such as therapies, pain management, equipment needs, education, counseling, family type issues that come up, and to maximize the quality of recovery for this individual. For today's talk, we'll use a pseudo-individual. We'll name him Patrick. Most patients involved with traumatic brain injury tend to be middle-aged males, risk takers, people who are driving fast in their cars. Typically, alcohol or drugs may be involved. There may be someone else in the injury as well, and that's even a more difficult situation. For the case of Patrick, we'll assume that he was alone in his car, that there was some alcohol involved, and somehow he ended up in a car crash. When I'm first consulted to see the patient, he'll typically be in the intensive care unit. He may be in a coma. He may have multiple other injuries, including fractured shoulders or broken bones in the face. He may have a broken leg, for instance, or a crushed pelvic bone, maybe even a vertebral fracture and some additional nerve injuries. My initial role at that time is to identify all of the ways that the diseases caused by the car accident are impacting the patient's motor function, sensory function, cognitive function. So my evaluation will typically involve examining their spine and the extremities and other neurologic reflexes, such as the ability to see, hear, and taste. For the case of Patrick, we'll assume that he was in a coma for a short time, and that as he's emerging from the coma, he's quite agitated, confused, and disoriented. This is almost always the case. We'll assume that in his brain scanning, there is collections of blood, or maybe that there's a fracture of the skull, and this has led to some obvious changes in the brain's morphology, probably leading to his behaviors. Typically at this case, we'll also find corresponding injuries to the limbs, and maybe there is a broken arm that's also paralyzed. It would be my job to find out which of the diseases is causing which of the impairments. So for Patrick's case, we'll say he's got a broken arm on the right side and also a broken leg on the right side. We'll assume that he's also paralyzed on the right side as well. Typically, paralysis on that side will also lead to difficulty with communication, and so we'll assume he has trouble communicating, speaking, understanding. This could also lead to trouble with mouth function, and he may not be able to swallow. So this is a very complex case, but certainly not unusual for the kind of accidents you see caused by motor vehicles. Motor vehicle accidents tend to be more severe because of the nature of high-speed impact and prolonged extrication times. People get trapped in these vehicles, and it may take 20 minutes, 30 minutes after the ambulance arrives before they can actually get the patient out of the ambulance. There's issues with oxygenation and punctured lungs, and there's blood loss. And so all of those issues are being tackled at a very high rate of speed with the care in an intensive care unit. About this time, I'm usually approached by the family, and the family are concerned about the outcomes. They're concerned also with the immediacy of the nature, but they're interested to find a person with my background that may have some indication about prognosis and about initial steps we can take for improving the function of the patient. I will typically give them a Rancho Los Amigos brain injury recovery scale. The scale helps a person understand some of the behaviors they're seeing in the individual. Issues such as agitation, for instance, which is otherwise described as a person who's very irritable and they can't stop moving their limbs. Anything touches their body and they're extremely irritated by it. In Patrick's case, we'll say, for instance, he's moving his left arm and leg and indicating that everything is uncomfortable. He doesn't want anything near him. He's pounding his fists against the rails, and he's trying to swing at people that are walking by. I would describe this as agitation. I would describe it as he could potentially harm himself or other people, and that we should control this with tranquilizers or sedating medicine. This will be typically happening already in the ICU, but the family who are wanting to see someone wake up out of their injury may not like sedation. They may feel that it is somehow impairing the person's recovery. This is certainly something that needs to be balanced carefully, and the risk of harm in the immediate situation is something that needs to be dealt with restraints or with medications or with one-on-one supervision. Typically, however, with the calming voice of a reassuring parent or spouse, Patrick may be able to calm down some of his behaviors that would otherwise take medications. And so I'll counsel the family to try to say things to Patrick that he would have otherwise heard normally. Something like, hey, calm down, you're doing okay. Hey, I'm right here by your side. This is your mom. Those types of reassuring voices could really get through to someone who can't otherwise understand what's going on around them because of their confusion. At this point, we'll try to come up with prognosis for what do we think is going to happen to a patient. This is all something that has to be done in the hospital because it really depends on the prognosis as to what we do next with the treatment program. We'll assume in Patrick's prognosis that within a few weeks he has started to follow commands. More gestural because he's having a hard time communicating, but with the right gestures and simple phrases, he seems to be able to do some automatic things such as roll side to side in bed, sit up in front of him, reach out with his left hand, shaking hands with people or grabbing on and holding on to items with his left hand. Maybe his right arm's in a cast. It's also paralyzed, and he may not even recognize that his right hand is injured in any way because of the cognitive trouble with his brain. He'll also be going through speech therapy at this time to assess at what level is he able to understand what is being spoke to him, and what is he able to communicate back. A person who can communicate is much less frustrated, and so they can begin to act more appropriately based on what's going on. When they can't communicate, they're usually typically scared and feel like they're all alone in their situation. Hopefully, if he's starting to remember some things and he's being able to follow commands, we've got a good sense that his Rancho Los Amigos recovery scale has gone up to a 5 or a 6. We'll see him less agitated. He'll be doing more automatic things such as trying to wash his face or feed himself. He'll be maybe predisposed to irritation, and so we'll need maybe some medicine to control some of that irritability. Or maybe his mood will have sunk very low as a combination of both the injury itself and maybe a reactive depression. He's starting to realize what's going on to him. This doesn't typically happen until the patient is out of amnesia. But as soon as they're out of amnesia and starting to understand the situation, it's something that really needs to be watched for closely. About this time, the patient will move to the inpatient rehab center. For our case, Patrick, he has obvious difficulty with his right arm, right leg, communication. His swallowing is impacted, and his mood is impaired. The inpatient rehabilitation focus will then be to take his strong side and build it up. He'll be compensating for his weakness. He'll be compensating for his inability to speak. We typically look at this level as dealing with his impairments. He can't stand. That's an impairment. It's not really the paralysis of his leg or the broken leg. Those are more the diseases. But the fact that he can't stand and walk begins to be addressed in the inpatient rehab facility. He can't wash his own face. He can't brush his own teeth. He can't feed himself or sustain his nutrition. He can't communicate with his family. These are impairments in his simple ability to do daily living skills, and these need to be tackled in a coordinated manner. My job in this facility is to really run the program. I'll understand the medical issues, the respiratory issues, the oxygenation, the low blood level and his tolerance to activity based on that. I'll also see what kind of pain he's in, what kind of medications he's on, and how these might further affect his ability to think rationally. I'll want to minimize the effect of any of the treatments that may be causing side effects, such as high-dose narcotics or tranquilizers. At the same time, I'll want to balance these medicines to give him the best quality of life through this period. Someone who's in horrific pain from a broken bone certainly can't concentrate on following the command to, for instance, wash their face. It's too painful, and they're obviously distracted by something more immediate. This is a very difficult balancing act, and so I'll use nurses and physical therapists, occupational therapists, speech therapists, psychologists, neuropsychologists, social workers, and other treatment team to really assess when is the patient doing their best, what are they struggling with. At the same time, hopefully we're allowed to start doing range of motion and treatments on the affected limbs. If his right arm is broken, let's say down by the wrist, can we start to have him moving his shoulder? Can we start to have him using the arm and leaning into his elbows, leaning side to side, and helping with his balance recovery? All of these things can be coordinated when you've got a treatment team of professionals in that inpatient rehab facility. Typically, these types of hospitalization treatments, the acute care hospital, the intensive care unit, and the inpatient rehab center, they're all hospital-level units, and they're covered by a regular medical insurance. They're covered by Medicare or Medicaid or Blue Cross. As the patient nears the end of this treatment program, now we see a wide variety in available treatments. The patient in an automobile accident in the state of Michigan is typically entitled to auto no fault. This allows us a wider array of treatment programs. You can imagine that because I'm on that inpatient rehab unit, talking directly with those therapists and those social workers on a daily basis or even sooner, and working on a day-to-day basis with them, we can really affect a greater recovery overall because of the coordination of care. With auto no fault, a person can typically be entitled to a day treatment program, for instance, a residential care center, a behavioral treatment center. He could be seeing multiple other physicians simultaneously with transportation, including wheelchair vans, and coordinated care with a case manager assigned by the auto company to help us coordinate multiple different doctor appointments so there isn't overlap and overuse of expenditures. That's a good system, and we've been lucky to have that system in Michigan for a long time. We'll assume for this case that Patrick has auto no-fault benefits, and because of his behaviors, he's been able to make progress in the rehab center, but he's maximized out until, let's say, his broken bones heal. We'll say, for instance, he's started to get back some recovery in his right arm and right leg, because we typically see motor recovery make some improvements in this arena. We use neurologic regeneration techniques, neurodevelopmental training, and other strategies which accelerate the healing process and the motor recovery process. Then we'll say he's about ready to leave the rehab facility. Maybe it's been 4 weeks. He's able to do a standing transfer. He stands on one leg, but he doesn't really understand that he's not supposed to put his right leg on the ground. He's got to have someone right by his side at all times for his transfers, and they basically remind him by tapping on his leg not to put that leg on the ground. With that tapping, we'll say he's able to understand the command that that's not a safe thing to do. Sometimes he'll try anyways, but with the staff right there, they're able to use an assistance belt. They're able to hold him up off that leg some as they remind him not to use that leg or his arm during the transfer. We'll assume he's still fairly challenged with his cognition. Maybe he's gone through some depression and he's on medication, But for the most part, through his day, he's peaceful, he's not agitated, he's not dangerous to himself or others, and we've begun to remove things like narcotics and tranquilizers and other medication, and gone on to use other brain medications that might reinforce some of his injured brain tissue. We'll use antidepressants to affect levels of serotonin or norepinephrine. Neurochemicals like these can be beneficial in brain function, and our brain secretes them. Antidepressants help more of those neurochemicals be in place to help brain tissue recover faster. We're using anti-seizure medicines to control overactive brain tissue, and neurostimulants to supply what brain tissue hasn't been present. And this combination is a balancing act once again. We try not to use medication at all, but when you can see a functionally important and a significant change in a person's behavior with a pill once a day, it's really an important part of our treatment in this day and age. Now Patrick's ready to leave the rehab center, but he needs 24-hour-a-day assistance everything he does, and he's forgetful, and he won't just sit in a chair. Neither do we want him to. We want him to be mobile. We want him to use his limbs in a safe manner. If he can be transferred at that point to a residential care facility, we can have staff that are trained 24 hours a day to assist people with brain injury, weakness, paralysis, frequent reminders, and personal focused objectives where they need to remember to, for instance, brush their teeth every day because too much bacteria in their mouth makes it a higher risk of aspiration pneumonia. A family can be overwhelmed with the situation. Some can take the person home, but 24 hours a day they've got to be right by his side. And you can imagine with the role that a mother and a son plays together, or a spouse and a husband, Patrick had better have someone that can both tell him what to do and be objective as well as be caregiving at the same time. That's a difficult role for a patient's family to play when they need this much care. And even if you're in a rehab facility for a month, you might need that much care still. We'll say in Patrick's case, he goes to the residential facility. At this facility, he's still receiving therapy, but it's a more home-like environment. He has a regular bed, for instance. He has a feeding tube. They're giving him oral feeding through the feeding tube. They're pouring a nutritional supplement into that, and it's coming in 3 times a day during meal times. He's sitting up during that, and he's allowed to drink plain water, we'll say, which is safe in his case, but not anything else for risk of aspiration. At this case, the treatment team at the residential facility continue to work on his care, but he's wearing regular clothes, and he's sitting in regular chairs. And when he goes to stand and walk, he's in his regular tennis shoes, for instance. He'll go through his follow-up appointments. And at this point, we're really looking at the roles this patient has in his life. We'll say Patrick used to go to his mom's house and help her out 3 times a week with her lawn care. How is she surviving now? How is she getting her lawn done? We'll look at him as being a husband, and that he was the main provider for a wife and, we'll say, 3 children. What's going on with this family? How's the wife handling this situation? How are the children handling it? Are they afraid to visit their own father because of behaviors that he might elicit, or because he's drooling, for instance, because he's got feeding tubes coming out of him? We'll help educate them, and we'll help get this gentleman back into a role where he looks like he's the father of a family. And when the kids come to visit him, he looks like he's injured and that he needs help to survive, but that the children aren't afraid to come up to him and hold his hand and sit on his lap or give him a card and try to talk to him. We'll train the family what's the best ways to communicate with him and what things can they understand that we can help them through. Where are they at with the grieving process? And really, what's the prognosis? Is he going to get out of this situation? Is he going to come back to be the sole provider for the family? Well, if it's been about 2 months or 3 months, we're going to have to temper some of those high prognosis. But we could get him back to communicating on a daily basis. And we definitely got him away from wanting to shake his fist at people and strike out at them. over the next month or two, or even several months, he'll get back to swallowing, most likely. And he'll get back to speaking, most likely. He'll get back to communicating on a daily basis, telling funny stories, laughing when the kids tell their stories, maybe not always interacting correctly, but we'll train the family what to do when something that he says doesn't seem like something he should have said. How do they respond to that? That family will be working with that treatment team, and they'll see how those trained professionals respond to Patrick's verbalizations that may not be accurate. And how do they redirect him, and how do they now learn to re-interact with their father, their husband, their son? That's a big part of what rehabilitation does, is helping this person's life and their roles they've played. Because really it's back to, we saved his life, we got him through the worst of it, and he may have a long life ahead of him. Statistically speaking, if he can learn to walk again once his broken leg is healed, and if he can learn to feed himself, he's probably going to have a normal lifespan. He's got caregivers around the clock, and so anything that he develops, such as pneumonias, are going to be quickly identified through these nurses or direct care aides. And so as we pick up these things, his life expectancy doesn't really go down. He may have fainting episodes or seizures. He'll be well protected from those. And as a result, he's going to live a long life with good medication. So we need that to be a quality outcome life. The rehab professional helps maximize that quality of life. We talked about how we interact with his disease process, with the impairments such as a weakened leg or a broken bone, with the disabilities such as inability to stand or walk or use his arms to take care of his daily routine. And then finally we talked about the roles that he's got. How can he be the best parent? How can he be a good spouse at this point? And what other issues are going on with him potentially returning to work? In Patrick's case, maybe he never returns to work, but maybe his interactions with his family, after 2 years at the residential center, he's ready to move back home with them. Maybe he's got an aide that helps him with his morning care, 6 hours a day. Maybe the wife has given up her job in order to take care of him, but now that the routine has been established, it's a comfortable relationship. And perhaps with his equipment that he's gotten, maybe he's more mobile. Maybe he can even get back to hunting with the right equipment, with the right friendships, and with the friends knowing that they can bring him somewhere and that he can be maintained and safe and really enjoy himself. Maybe he likes bowling, and we've got equipment that we can get him back to for bowling, or golfing, adapted equipment for golf. So we can really give him back a lot of his quality life. He can go on vacations with the family. He can go on trips to Florida, for instance, in the wintertime, and they know how to do his care. This is really the goal of a physical medicine and rehabilitation specialist. Now, I'll make this one note. Without an auto insurance, let's say he doesn't have auto insurance. For some reason he was uninsured victim or an uninsured driver. Now we've got a whole different situation. When he leaves the rehabilitation facility, you remember he was unable to walk or stand. He needed 24-hour one-on-one assistance right next to him. We'll say that he went home with the family and had to try and do that. I'll assume that the family couldn't really do that very well, or that 3 or 4 people had to give up their jobs in order to provide that level of care for him. The reports I'll get back from the family are going to be much more variable than the structured reports I would have gotten back from the residential care or from a day treatment program or some other type situation. They're not going to know the language to use to communicate with me things about seizures or tremors or spasms or pain, especially if the patient has a hard time communicating those same issues to them. My treatment program is going to be a lot different in that situation. I'm not going to really want him to walk at all. I'm going to want him to stay in the wheelchair, and I'm not going to trust that the family can really get him mobile until the orthopedics release him from non-weight-bearing status. By then we may have other issues such as contractures or bed sores. Potentially, Patrick, even without insurance, could have done a pretty good job in a wheelchair until he's able to walk, and then still got back to walking. Potentially he gets back to hunting or going on vacations. But you can imagine the turmoil for that year where 5 or more people of this family have had to give up their lives to take care of Patrick in his devastating situation. It can work out, and in other states, in Michigan, where they don't have the kind of benefits we do, we see typically the patient's family either has to do what they have to do, or the patient will have to go to a nursing home. The nursing home isn't such a bad situation because you do have nurses around the clock, you have caregivers and such. But the tendency in a nursing home is to promote sedentary lifestyle. Typically, nursing homes are known for end-of-life care, and so most patients aren't looking to make improvements. There are treatment programs for people making progress, but if it's going to take someone a year or so to make that kind of progress, they're really going to struggle following that kind of progress at that slow of a pace when they're not traumatic brain injury specialty type service. So I would certainly say that if I can really use the environment of care, I can maximize the treatment program, I can coordinate the efforts of multiple treatment team members, I can listen to the verbiage and vocabulary used by the treatment professionals, and I can train the patient's family on a much faster and more efficient process with the right insurance, with the right payers, with the right treatment teams, with the right environment. And that's so important to people's recovery. That about wraps it up. I appreciate you listening.